Greetings. I'm Bruce Oviagale, the president of the Society for Equity Neuroscience. I'm delighted to welcome all of you to the May edition of our Disparities Dialogue series. I am honored and grateful that we are talking about neurocritical care this particular month. We have an outstanding group of experts here to share their knowledge, wisdom, and experience with us. First, we have Dr. Aimee Aysenne, who's at Tulane University. Next, we have Dr. Oliver Otite, who is at Upstate University. And last, but by no means the least, we have Dr. Tommy Thomas, who's at Emory University. Welcome, all of you. So we'll start off by going over the 9 articles we hope to talk about today. The very first one looks at the issue of the landscape of disparities in OBS neurocritical care and seeking a path forward. The next one looks at an evaluation of neighborhood resources for ped status epilepticus outcomes in the ICU across the US. The third article examines neurocritical care in resource-limited settings. And as you will notice, we'll then begin to focus on that theme as we go on. We take a look at neurocritical care organization in low to middle income countries. We'll take a look at the urban-rural divide, again, in neurocritical care in low to middle income countries. We'll then shift to the issue of demographics and examine race, ethnicity, and gender disparities in the management and outcomes of people who are critically ill with stroke. We'll examine again the issue of racial and ethnic differences in terms of withdrawal of life-sustaining treatment and hospice referral in people who have severe traumatic brain injury. We'll then go ahead to examine a culturally centered palliative care approach, leveraging a framework for equitable neurocritical care. And then finally, we'll come into the modern age and examine the issue of digital health, looking at the issue of remote neonatal neurocritical care from the bedside to the cloud. So I'm very excited about this. We'll now launch into our article discussions. The very first paper is a paper that was published in Frontiers in Neurology, looks at the issue of the landscape of disparities in obstetric neurocritical care and a path forward, led by Shilpi Mittal. And Dr. Aysenne is going to kindly walk us through this paper.
Thank you. So a little bit about the background. This was a paper that was looking at health disparities in obstetric care, specifically related to maternal morbidity and mortality. As we know, pregnancy increases the risk of some neurologic conditions, including ischemic stroke, intracerebral hemorrhage, and cerebral venous thrombosis. And pregnant patients can experience concurrent neurocritical care diseases such as status epilepticus and TBI. For methods, this is a review article. It was published literature that was defining the disparities of both obstetric maternal care and neurocritical care. There's very little about the two at the same time, but certainly looking at the landscape of both separately and then together. So again, defining the landscape and suggesting some possible solutions to these disparities. So the findings, there were several studies that have just demonstrated disparities affecting maternal morbidity and mortality during pregnancy. Maternal mortality rates have been actually increasing over the past 3 decades, which is quite concerning. Black women and American Indian and Alaska Native women have the highest rates of pregnancy-related morbidity and mortality. For Black women, that's 42.8 per 100,000 pregnancies. And for American Indian or Alaska Native women, that's 32.5 per 100,000 respectively, which is significantly up from other ethnic and racial groups. Disparities in obstetric care exist in rural versus urban areas as well. Patients with substance abuse disorders and those who identify as LGBTQ+. There are some limitations of this study, of course. There's a lack of evidence about pregnant neurocritical care patients in general and the disparities that are affecting them. There are limited solutions that are evidence-based for improving outcomes, and there are major gaps in research that were delineated in this publication. So in conclusion, disparities in maternal health care and neurocritical care are well reported separately. There's no evidence of these disparities dissipating. And pregnant neurocritical care patients face overlapping risk factors that can affect acute neurologic disease and their outcomes. So the implications of this, we have some actionable solutions that can decrease disparities of care at an institutional, regional, national, and global level. We want to really bundle guidance and standardization to decrease bias and structural racism within care. Future research should be focused on these large gaps and disparities, particularly with obstetric neurocritically ill patients. And of course, we need a multidisciplinary, multidimensional approach to eliminate disparities that are associated with these patients.
That's superb, Aimee. Thank you so much. A very important area. Did you want to highlight anything in this table?
Yeah, absolutely. So this was a list of the disparities that they found. Both, again, they did it separately with obstetric maternal care and neurocritical care, and looking at those things that might have affected both conditions. So we looked specifically at maternal mortality rates, again, as described before, hypertension, and the risk factors that are associated with neurocritical illness, so hypertension, cardiomyopathy, thromboembolic complications, general obstetric comorbidities, miscarriage and stillbirth rates, and postpartum hemorrhage, all of which have been higher in patients who are of racial or ethnic minorities. And then from a neurocritical care perspective, we're looking at maternal stroke. Maternal stroke associated mortality is higher in Black women specifically. Hypertensive disorders of pregnancy, hemorrhagic stroke, subarachnoid hemorrhage, cardiac arrest, which is a huge topic in and of itself, and traumatic brain injury during pregnancy and status epilepticus. Again, those are conditions that can happen at any point in a person's life and can also happen during childbearing age and during pregnancy.
No, thanks, Aimee. Well, these type of OBS, neurocritical care emergencies, tend to be low frequency but high acuity. What strategies do you think are most important for preparing providers to respond effectively and equitably?
Yeah, so I would start with, we have to have a multidisciplinary team. And obviously, these two teams don't interact on a daily basis. And so thankfully, these are low frequency, but they're associated with such prolonged downstream complications that can be affecting both mother and child. I think in general, people are afraid of neurologic illness. And so when you start having a gynecologist who's managing a neurology issue of any sort, there's certainly some concern about their ability to do so and some nervousness that comes into play. And then from the neurocritical care perspective, I've certainly heard colleagues that are uncomfortable with managing patients who happen to be pregnant. But we always have to remember that a healthy mother is the best way to have a healthy baby. And so we must treat the mother as in our best evidence as possible when we don't have anything else to guide us.
Absolutely. I see that Tommy has his hand up to talk, add a comment or a question to this. Tommy, please go ahead.
Yes, I was wondering about, so we've all probably written chapters on pregnancy and neurocritical care or read the literature. What do you think the path forward is to really start registries between obstetrics and neurocritical care and really kind of removing the silos that currently exist? I mean, we have these disparities that are prevalent through both endeavors that we'll talk about later. But what do you think is the best path forward?
Yeah, I think obviously starting with the communication of these two teams, just making sure that we are talking to each other as colleagues. I think a registry is a great idea. Again, we have such a low frequency of these conditions. Having organizations that help to sponsor these registries so that it's not one institution. A single institution may see a handful of these cases in a year, but really having a global registry of these patients would be certainly beneficial to have a better understanding of the conditions that we're talking about here, and to come up with some solutions for how do we care for them.
Well, that's
What
excellent.
worked and what didn't.
No, that's excellent. And it's wonderful they were talking about this issue of trying to get collaborations between departments and services, between organizations, maybe even between societies. But Aimee, what do you think that bedside clinicians can potentially do to minimize the risk of their pregnant patients experiencing these disparities?
Yeah, we certainly need to start with listening to our patients. We know that there is a huge disparity when we talk about um, a, a patient and a provider who have different racial or ethnic backgrounds, and the amount of time spent listening to those people, to our patients. And so making sure that we have open communication, that we can hear their concerns. Sometimes the cerebral venous thrombosis, for example, may just present with a headache. And so if someone doesn't pay attention and listen to what the symptoms are, then, that might be sort of ignored or moved on, and not really taking it with the severity that it should deserve and the seriousness it should deserve. I think about the case of Serena Williams, for example. She obviously is a well-known, very wealthy Black woman who knows her body more than most, I'm assuming, given her profession and her, GOAT status. And still, she was not immune to this bias in healthcare providers, ignoring her symptoms as she made it known that she was having symptoms of a DVT and subsequently a PE. So
Oh, thank you for that. Yeah, great anecdote. Thank you so much. We just want to invite Oliver and Tommy. Any further questions or comments about this one?
None.
Oliver? Okay, Oliver, go ahead, please.
None for me. No
You're good?
comments.
Okay, Tommy, any? You good? You're good. Okay, excellent. We'll move to the next one then. And the next paper was published in the Journal of Child Neurology and looked at the issue of examining neighborhood resources and pediatric status epilepticus outcomes in the ICU across the United States, led by Kara Garrett. And so, Aimee, if you don't mind walking us through this one.
Sure, thank you. So a little bit about the background. Status epilepticus is the most common pediatric neurologic emergency. We know that racial disparities have been described with outcomes associated with epilepsy in general. There's something called the Child Opportunity Index, which measures neighborhood resources and conditions for healthy child development. There are 44 indicators across 3 domains, and they're divided into quintiles. So those quintiles are very low, low, moderate, high, and very high resources that are available to children in specific neighborhoods. So the methods of this study, it's a multidisciplinary or multi-center retrospective cohort study. It used the Pediatric Health Information Systems database, which is comprised primarily of tertiary referral centers in the United States with children aged 1 month to 21 years old. And it was used to evaluate ICU outcomes for patients with epilepsy and presenting with status epilepticus as per the Child Opportunity Index. So the primary outcome measure was the association of the Child Opportunity Index with invasive mechanical ventilation for status epilepticus. Secondary outcomes included the association of Child Opportunity Index with the use of vasoactive medications and hospital mortality. So the findings included a cohort of over 17,000 epilepsy patients across 49 tertiary children's hospitals in the United States, all of whom were admitted with status epilepticus. There was a significantly higher proportion of patients who were from very low Child Opportunity Index neighborhoods compared to those with very high Child Opportunity Index neighborhoods. Those percentages for very low were 26% of the patients in the cohort, and for very high, it was only 16%. Obviously, that was statistically significant. Compared to children with a very high Child Opportunity Index, those with very low, or moderate Child Opportunity Index were more likely to receive mechanical ventilation compared to those who were in the very high Child Opportunity Index quintile. I have included here the adjusted odds ratio for each of those cohorts. There were no difference with the use of vasoactive medications or in-hospital mortality. Obviously, there were some limitations of the study, as there always are. First is that this used an administrative database which uses ICD-9 codes, and those have been shown to be prone to error. There was no method for adjusting for disease severity within the Pediatric Health Information Systems database. And the database is from tertiary children's hospitals, which tend to be large and urban. And patients presenting to community hospitals or those more likely to present in a rural setting were not captured in the study at all. So in conclusion, children who are admitted with status epilepticus from very low, and moderate child opportunity index neighborhoods were more likely to receive mechanical ventilation compared to those in very high child opportunity index neighborhoods. This is the first study to demonstrate neighborhood level disparities for children with epilepsy presenting with status epilepticus to an ICU. So the implications for this study include the need for additional investigation to evaluate these disparities in epilepsy and to promote systemic changes, including potentially flagging patients from at-risk neighborhoods and acknowledging that they may benefit from increased resources. The interventions could result in long-term health savings for health systems by decreasing utilization of the most high-cost resources in the ICU, while also decreasing inequities that are associated with status epilepticus outcomes.
Thanks, Aimee. Again, another important study. So as you concluded, the study found that children who were admitted with status from very low or moderate, in other words, lower COI neighborhoods were more likely to receive mechanical ventilation. Yet there was no difference in terms of mortality. What might be the mechanisms underpinning this particular disparity, do you think?
Well, there's several things. We've already demonstrated significant disparities that are associated with the outcomes of epilepsy in general. There's tons of reasons why that's the case. Certainly opportunity to access the health system in general is a starting point. But it also includes, delayed access to outpatient clinics, provider to patient disparities in general, other issues that affect trust of the system. And we have also shown decreased compliance of anti-seizure medications in these cohorts, which certainly will make status epilepticus more likely and more severe for those patients. They also may be further away from the tertiary care center that they're receiving their definitive care. So it doesn't really demonstrate if these patients, for example, were transferred into a children's hospital and needed to be intubated for transport. It also doesn't include anybody who was outside of a tertiary care center that provides the highest levels of care. So we certainly have gaps based on not just, this is obviously a geographic gap that we're demonstrating. We've demonstrated the racial inequities, and certainly it falls under racial lines as well. When they look at what defines a neighborhood of the Child Opportunity Index, it's certainly racial and ethnic minorities fall along the trends that we have seen so frequently and are at play here as well.
Absolutely. Tommy, please weigh in.
So I wanted to kind of highlight and ask a question about why the etiology of this, what your thoughts were, because we already have that in the COI neighborhoods, low COI. You already see the increase in asthma severity, and this is not only a geographic representation, but there is an environmental equity issue and exposure equity issue that exists within this. I don't know whether the prevalence of status epilepticus is higher in those neighborhoods as well, but even if we're speaking about just the necessity of mechanical ventilation, I think that would correlate with the environmental factors that likely led to the asthma severity increase. And so I guess what do you see aside from, so often we talk about highlighting the problem, but what do we see as kind of solutions, especially in the case that mortality didn't differ, but we did have this increase in utilization? What do we see as kind of our solutions? Is it environmental? Is it other things? What realistic interventions could we do?
I think you bring up some excellent points, and it is a very complex problem to really dissect out. So we can even talk starting about the last paper that we reviewed, which was a disparity of maternal care. So, are these patients who are being born, these new children coming into the world with a disadvantage because of their maternal prenatal care? And you talk about environmental risk factors, but healthy baby, healthy mom equals healthy baby, and we're already not doing the best we can for all mothers across the board. And now you have a child who has an increased risk of having a neurologic condition in general. And so, the system from every point is being strained. And when we break it down and dissect it out, we see the inequities at every single level. You go back to, when people really look at disparities in healthcare, one statistic that always stands out to me is that you can look at income level and then subsequent education. So it always comes back down to education too. So, if you follow the trail far enough down, you'll see that the real root is making sure that everybody has access to all needs across the board, not just one particular thing. We can, I think we could talk about putting more resources specifically for epilepsy in these communities, but it's really an overhaul of what the community needs in totality.
No, so well said. And it kind of leads into the second question I have, which touches on Tommy's question about solutions, but also touches on your last comment about trying to put more resources in the neighborhoods, which is how could healthcare systems potentially take these findings, address them, but yet not stigmatize the same neighborhoods or populations?
Yeah, I think, that is always the challenge is sort of all boats, rising all boats, not just having one specific area. I also think that having solutions that are coming from these neighborhoods, listening to communities to have culturally appropriate care is so incredibly important. You want to make sure that people understand why their children needs medications for seizures, for example. That is an important aspect of making sure they're not presenting with status epilepticus in general. And so that might be having a social worker who's from that community really representing them and explaining things in a way that is culturally appropriate and culturally sensitive.
Yeah, and I think that's spot on. And I've argued in the past and still do about having community advisory boards, that every neurology department, especially big ones, should have community advisory boards with standing members where you can actually, as you said, get the perspectives and the input and the buy-in from people in the community so that we're really doing right by them. But no, completely agree. And thank you for that. It's really a great paper and illustrates a number of very important things. We'll move on to the next paper, which looks at the issue of providing neurocritical care in resource-limited settings, examines the challenges and opportunities, was published in the journal Neurocritical Care, and was led by Morgan Proust. Thank you, Aimee, for walking us through this one.
Of course, thank you. So a little bit about the background. Acute neurologic illness contributes significantly to the global burden of disease and causes disproportionate amounts of death and disability worldwide. Low income and middle income countries lack neurocritical care resources in a variety of ways and expertise, with subspecialized neurocritical care largely absent outside of high income countries. The methods of this paper include, again, a review article of the published literature and a statistical review with added expert opinions for recommendations. The findings include more than 70 countries have less than 5 ICU beds per 100,000 population. That's significantly reduced from a high-income country. CT scanners are also limited with 1.3 scanners per 1 million population in low and middle-income countries, while we have about over 20 scanners per 1 million population in high-income countries. Stroke is the leading cause of disability worldwide and is the second leading cause of death worldwide. And with that, the burden of disease again falls on these low and middle income countries, with 58% of strokes occurring in low and middle income countries and 67% of stroke-related deaths occurring in low and middle income countries. Motor vehicle accidents are also a leading cause of death worldwide, particularly in individuals in their young adulthood between 15 and 29 years old. And falls are a primary cause of traumatic brain injury worldwide, with obviously an increased risk in the elderly population. There is also disproportionately greater incidence and mortality associated with traumatic brain injury in low and middle income countries, but the data is very incomplete. Most epilepsy cases and related disabilities and deaths occur in low and middle income countries compared to high income countries. Several of these factors include increased risk factors for seizures, including CNS infection, TBI, and again, birth injury. There are added burdens, including limited access to EEG, neuromonitoring, and delays in diagnosis, and limited availability of anti-seizure medications. And many of them that they use in some of these places are not the most current medications that we use in high-income countries. For example, phenobarbital being quite prominent. CNS infections, including tuberculosis, encephalitis, and HIV-related complications, remain elevated in low and middle-income countries compared to high-income countries. So there are limitations, of course, to this paper as well. There are limited published resources for the treatment of acute neurologic illness in low and middle-income countries. Resource-limited settings rarely participate in clinical trials. So the evidence that we do have, the evidence-based care, is extrapolated from the literature from high-income countries, which may not be applicable in these settings. For advanced modalities to work, such as multimodality monitoring, which we're doing more commonly in high-resource settings, may be beneficial. But for this to actually work, we must first meet basic resources, including access to neuroimaging, mechanical ventilation, EEG monitoring, and increased specialized nursing care. So in conclusion, opportunities exist in resource-limited settings for expanding research on best practices for acute neurologic injury, for developing systems for effectively triaging patients for the most benefit. So we really want to take a young person who has years of recovery and who has high potential for improvement of their neurologic illness and treat those patients, more severely. In the United States, in particular, we often focus on those who are older individuals with chronic illness in our ICUs, but we really want to target those who we can get through their acute illness and then lead to a long, happy life. So again, broadening the neurologic workforce with training pathways is very important, including fostering and retaining local expertise. Again, that community-based, it has to be from the communities with local expertise in low and middle income countries. So the implications of this, again, expanding capacity in resource-limited settings that are likely to benefit individual patients, their communities with increased total life years saved, integration into society, and return to productive work.
No, thank you, Aimee. This article, like many of them, struck home. The way when I read it, three things came to my mind: the issue of expertise, the issue of resources, and the issue of context, which you brilliantly touched on throughout that. I'll put a little pressure on Oliver and myself, because when you look at this, in many of these places, there's a dearth of expertise already, right? Then you have people like Oliver and I who trained in these places. Then we come out here, and so already they had limited expertise and capacity, and then we further drain that brain, so to speak. Brain drain. That's right. Yes. We brain it even further, not to make you feel guilty, Oliver. It's the same for me. And so it just makes the whole issue even worse. But I completely agree with you about the context. Like, we take high income country evidence, apply it to low income country. Sometimes it's not applicable because it's just the wrong context. Sometimes it's because the resources aren't there to do it the way it should. But Aimee, to your mind, how can we do a better job in this area to try and make sure that interventions that are developed in one setting can achieve at least similar or near similar results in these under-resourced settings?
Yeah, I think I first want to comment about what you said. There's some data from Zimbabwe saying that what we do in the United States about fluids and septic shock, for example, has deleterious outcomes in a different setting. So what we're talking about is not as complex as we think. Even IV fluids can be the wrong thing to do in certain settings. And so this is more about knowing the setting than anything else. So I wanted to really talk about kind of what came next from this paper and what it led to. So Morgan Pruist is a neurointensivist who's out at Yale and really led an initiative to go into the African countries in the continent and hosted emergency neurologic life support, which is ENLS, sponsored by the Neurocritical Care Society. And he hosted the course. And then after the course, he asked those who are in those settings, what interventions could they not do? So what do you do instead? So, a collaboration of really asking the questions, what do you have available? What do you not have available? And how can we extrapolate the data that we have to give the highest level of care? So over the course of about 6 months or so, I was actually on this panel where we met biweekly with representatives from different countries in different settings, some rural, some in bigger cities in Nigeria, and a variety of different roles as well. So neurosurgeons, nurses, ran the gamut of people caring for these patients, and said, what do you do? How can we do it? And what is the best evidence? And so we developed a pathway that accompanies ENLS that is actually part of every single module. So 14 modules. Now the resource limited ENLS is part of every single one of those to make sure that patients are getting the best care that they can have wherever they are.
That's fantastic.
Those modules are currently available on the NCS website, and they're open for free for the public. So you can access it, and we don't have a paywall in front of it. Some places are also using hard copies because they know that they don't always have readily access to a computer if you're in some of those places.
It's very impressive work by Morgan. Tommy?
So that all kind of highlights the heterogeneity that we see between low and middle income countries. We often compare them and say that one LMIC is the same as another, but they have different cultural and resource differences that we need to highlight. How can we effectively kind of beyond like the obvious, going in and having community advocates and local representatives that really build the system and tell you what they need? How do we do this without kind of the paternalistic pitfalls of kind of the global health community? I know ENLS is trying this. The Herd Center within Neurocritical Care, the Henderson Equity and Research on Disparities Center is looking at types of problems and coming up with solutions for this. But how do we avoid the pitfall of global health, where we come in as the three of us are not, but the great white saviors, and really kind of come in and paternalistically tell people what they need locally rather than asking them and helping them achieve?
I won't take that great white savior comment personally, given the current panel. Regardless, I mean, it all goes back to sort of the things from the previous papers as well. It's having community representation at the table, making sure that we are training the trainers as best we can, and also listening to where deviations must happen in order to have a successful implementation. There's no way that we can come from the outside and say what someone else needs. It's just, whether that's in a community in the United States, whether that's in a different country, whether that is, it doesn't matter. We have to have community engagement and community advocates who can help to really spearhead improved care for patients.
Oh, absolutely. And I think it's really about trying to make sure things are contextually appropriate and sustainable. And so to your point, Tommy, of course, people helicoptering in, doing wonderful things and then leaving, while helpful and welcome, is probably not the long-term solution to many of these things. And Aimee, to your great point, first of all, we need all hands on deck, regardless. That's number one. But two, also, we also need to be able to consider developing contextually appropriate guidelines. So bringing people together, as you rightly said, Tommy, not all these countries are the same, but many of the things are the same. And to even a larger extent, there are some similarities between some low to middle income countries and underserved regions of high income countries. So to the extent that we can even bring people together to all learn from each other. Again, to your point, there are differences, but where are there commonalities and how can we learn from each other? No, great discussion. Love it all. Oliver, any comments or are you good? You're good. He's good. All right, good. Thank you, Aimee. Fantastic. Really appreciate that. Oliver is going to take over now and guide us through the next three articles. This fourth one looks at the issue of neurocritical care organization, again, in the said low income and middle income countries. This paper was published in 2025 in Neurocritical Care and led by Himanshu Brabka. All right, Oliver, please guide us through this one.
Yeah, so evidence shows that patients with acute brain injuries have better outcomes when managed by dedicated neurocritical care teams. And this has contributed to the rapid expansion of neurocritical care as a subspecialty in high-income countries over the last 2 decades. However, this growth has not been matched in many low and middle-income countries, where access to ICU beds, neuroimaging, neurosurgical specialty, and specialized expertise in general remains limited. In 2020, the Neurocritical Care Society conducted a point prevalence in neurocritical care study called PRINCE. But this study essentially provided a global overview of neurocritical care practices, but many low middle income countries were not represented. Notably, no African countries were included, and this sort of limits the generalizability of PRINCE to resource-limited settings. So this study by Prabhakar and his group was designed to give a more direct picture of what neurocritical care organization actually looks like across low and middle income countries. This was a cross-sectional survey. The authors essentially surveyed 408 healthcare providers from 42 low and middle income countries. The survey looked at whether institutions had dedicated neuro ICUs, what types of clinicians were providing ICU care, what technologies were available, and whether hospitals followed protocols for common neurocritical care conditions. They also compared responses by geographical region and by World Bank income categories, which by at least by categorization were low income, lower middle income, and upper middle income countries. So the goal was not just to say that low middle income countries have fewer resources, but to actually give some context and describe how neurocritical care capacity varies across regions and economic strata. The most important finding is that neurocritical capacity is actually highly variable across LMICs. Only about a third, 36.8% of respondents reported access to a dedicated neurocritical care unit or neuro-ICU. There were also major differences across regions, with some regions reporting much greater access to dedicated units than others. For example, notably, the dedicated neuro-ICU prevalence was sort of low in sub-Saharan Africa compared to the Middle East. There were also important workforce gaps that were highlighted. In many institutions, ICU care for neurocritical care patients is not provided by dedicated neurointensivists, but mainly by anesthesiologists, sometimes by general intensivists, residents, medical officers, neurologists, neurosurgeons, and other clinicians made up the majority of the workforce. This is somewhat important because neurocritical care depends not only on having ICU beds, but also on having trained personnel who can recognize neurologic deterioration early and institute appropriate management early while coordinating other aspects of care, such as airway and ventilation care. Another important finding is that access to specialized technologies and services varied widely. Dedicated transport teams, portable CT scanners, tele-ICU, and telemedicine for remote hospitals were not consistently available. These findings somewhat show that neurocritical care organizations, just as we've been talking about as a prelude from the article discussed by Aimee, is not uniform. Some institutions have relatively advanced capacity, while others are still developing their core care services. The study also showed that protocols varied substantially across hospitals based on whether they had dedicated neuro ICUs or not. Dedicated neuro ICUs were more likely than non-neuro ICUs to report following evidence-based protocols for management of common neurocritical care conditions, such as acute ischemic stroke, traumatic brain injury, subarachnoid hemorrhage, intracerebral hemorrhage, and status epilepticus. Across income regions, protocol adherence was generally lower in low-income countries and higher in upper-middle income countries. This is somewhat important because protocols may be one of the most practical ways by which we improve consistency in the care of neurocritical care patients, even when resources differ between hospital settings. One major limitation of the study is that it was a survey, so the data is essentially self-reported. So the findings may somewhat be affected by response bias or by differences in how respondents interpreted the questions that were asked of them. Another limitation is that respondents were more likely to come from urban or academic centers in the countries that was surveyed. Because of that, the findings may not fully represent smaller hospitals, rural hospitals, or even facilities with fewer resources. So this study, though important, may not capture the full range of neurocritical care practices, even in these low-middle income countries settings. And there's also, just like we've said in our prior discussions, there's also variability within LMIC categories in themselves, including low-income countries, upper and middle-income countries, regarding their healthcare capacities, and even within the same country, there are large differences between hospitals and regions in terms of their clinical care practice patterns. Yeah. So in conclusion, there are major differences in the availability of dedicated neuro ICUs, trained workforce, specialized service technologies and protocol implementation, with biggest gaps in low-income countries and sub-Saharan Africa. There's a need for strategic investment in neurocritical care capacity, neurocritical care specific training, and other scalable, affordable technologies are sort of needed in these areas. In terms of implications, just like we've said, the implication is that neurocritical care development in low and middle income countries has to be content specific. A one-size-fits-all model, essentially borrowed from high-income countries, will not necessarily work. Different countries and even different hospitals within the same country may need different starting points. Expanding neuro ICU availability is a critical infrastructure priority. But more importantly, there's a need for neurocritical care specific training programs and fellowships to address workforce gaps, using anesthesia residents as the primary 24-hour coverage model is maybe not sustainable in the long term. Some hub and spoke telemedicine models and low-cost monitoring technologies may be near scalable and near-term solutions to bridge gaps in settings where that would allow for that such.
Oh, thank you so much, Oliver. Before I go forward and ask you a few questions and also invite Tommy and Aimee if they have any questions, I know you have this graphic here. Did you want to talk to this at all?
Yeah, this is just an overview of the countries that were that were included, of the countries that were included in the survey. And majority, as you would see, were about a third were from South America. Um, India represented about 17% of the survey responses, but in terms of geographic distribution, it's sort of more widespread than across sub-Saharan Africa and even the Middle East as well.
Yeah, no, and looks like you've excited both Aimee and Tommy. Before they weigh in, I'm just gonna. Your point is so well taken that the poorest of the poor were not necessarily involved in this particular survey, and even when they did do surveys in these countries, they tended to focus on the urban and the academic, right? But the issue of validity is very important here, and I'll wait to hear what Aimee and Tommy have to say. But my question for you to muse over is, what did you think about the validity of the survey questions themselves to really capture the real world neurocritical care implications of doing care in very poor settings? So that's just what I want you to help me answer. But I'll call on Aimee first to weigh in, then Tommy, and then please let me know what you think.
Sure. I guess another part of survey, how the survey was conducted was how did you find the participants? You know, the Prince study was really used Neurocritical Care Society as the local hub to then send out those surveys, you know, to see a day in the life of a neurointensivist. And so certainly had neurointensivists primarily involved in filling out those surveys. But here you were really looking at places that did not have neurointensivists. So how did you find participants to actually even do the surveys?
Yeah, so that's that's a very important question actually, because it's just from my review of the what do you call it, of the study. The first part of your question is there was no report on what even the response rate was for this initial survey respondents. How many of the respondents actually from how many surveys they sent out and how many respondents they got. All we know is that they had 408 respondents at the end of the day. They essentially just contacted individuals in these various countries, and based on whether on who it's not based on, and some of it was from the Neurocritical Care Society background, but some of it was also just from by who I would say who knows who. I would say. So their definition of neurocritical care providers in this region was essentially anyone that was involved in the care of neurologically injured patients. So it's not we in terms of that's a major limitation of the study in that sense, because it biases the sample of respondents, and also maybe even overinflates the availability of neurocritical care services in these underrepresented areas, I would think.
That's interesting. Before Tommy comes in, I just wanted to. I didn't realize that because again, all of us write papers, review papers, some of us edit papers. That's an important issue that they didn't report the respondent rate. So we don't know what the denominator was here, because typically what you would like is to have the response rate and then to potentially compare those who responded versus those who did not respond to see if there are any differences that might have influenced things. But again, no study, as Aimee mentioned, is perfect. There are always limitations, but it's important for us to consider that as we take in the implications of these findings. Tommy, your thoughts?
I mean, that brings to mind the heterogeneity between LMIC and how that label is too all-encompassing because here we see a huge chasm between sub-Saharan Africa and Latin America, but we know that Latin America has a lot more infrastructure than sub-Saharan Africa. Cuba and Brazil have stroke and ICU networks. There's neuroanesthesia and neurocritical care in Argentina and Mexico. And so I guess how do we re-stratify in order to really dig into the differences between LMIC so that we can actually bridge the gap that exists between sub-Saharan Africa and Latin America and really address those needs. That was my thought, and I think the sampling bias really kind of addresses that and points to that as an issue because we don't know where these people really came from, and so we don't really know the differences between the LMICs and the resources that they have.
No, and it's a fair
Good
point.
point.
Go ahead, Oliver.
Dr. Bergley, to address your earlier question, actually,
Yes.
I would say, despite the limitations, this study still highlights the scale of neurocritical care resource gaps or at least makes us start to have this discussion about it, in that, which is, I think, on its own is very important. But it also sort of highlights how profound the infrastructure divide is between low income and high income health systems. In many low income settings, at least particularly in sub-Saharan Africa, which I'm very aware of, questions about possible portable CT scanners, tele-ICU capacity, or tele-neurology is very far removed from day-to-day clinical care, clinical reality. So, for example, the issue in some large referral or teaching hospitals in Nigeria, which I'm very familiar with, is not whether a portable CT scan is available, but whether there's any consistently functional CT scanner in the first place. While tele-ICU and tele-neurology are increasingly discussed as solutions for expanding care, generally, their visibility essentially depends on foundational infrastructure such as reliable electricity, which in many parts of sub-Saharan Africa, even in teaching hospitals in urban areas, is not very consistent. Internet connectivity, trained personnel, and basic medical care and critical care capacity in that sense. In many low-income countries, at least in sub-Saharan Africa, even these prerequisites remain inconsistent, I would think.
No, great points. And I don't want us to beat up this one too much. I'll just finalize by saying that maybe in the future, and some studies do this, rather than just say, as you alluded to, Tommy, about just low to middle income countries, but looking really at GNI, gross national income, or looking at GDP and trying to use, again, that's not perfect. There's still going to be differences, but as you said, it's really hard to make anything when you have comparisons like this. But again, as Oliver rightly said, this starts the conversation. We need to keep doing things and keep raising things. So we don't want to make the perfect the enemy of the good. No, wonderful. Our next paper looks at the urban-rural divide in neurocritical care in LMICs, a paper that was published in Neurocritical Care in 2024, led by Charu Mahajan. And Oliver is going to guide us through this one.
Yeah, just as a continuation of, I think the theme is sort of continuing, is really about how the fact that neurocritical care does not happen in isolation. The authors use rural-urban divide to show how much the outcome of neurological emergencies depend on the broader health system in that sense. In resource urban settings, we usually think about neurocritical care in terms of specialized neuro-ICU staff, imaging and advanced neuromonitoring, and protocolized management. In many rural areas, even in high-income countries, most of these infrastructures are lacking. Rural populations as a whole face geographic isolation, infrastructure gap, specialist scarcity and economic disparity. But because LMICs have a larger population of rural patients, up to greater than 50% for the most part, the brunt of these disparities more marked in these areas. So this is essentially a narrative review, not a systematic review. The authors are not trying to pull data or do a formal meta-analysis. Instead, they're using available literature to and examples from common neurocritical conditions to describe rural-urban gap in low and middle-income countries. They discuss 6 clinical conditions: stroke, traumatic brain injury, epilepsy, myasthenia gravis, tuberculosis meningitis, and tracheostomy, and use these examples to show how rural patients are disadvantaged at multiple points in the care pathway, essentially. So the main point is that rural disadvantage affects the entire continuum of care, not just what happens inside the ICU. For stroke, the issue, they started by discussing about differences in stroke subtypes. There may be subtype differences between stroke in rural in populations and in urban populations. But interestingly, the reference for this was not a study from a low middle income country. It was from France. And which is not essentially a low or middle income country in that sense. Stroke prevalence is notably across board higher in rural areas. The issue is not whether thrombolysis or thrombectomy is available. The more basic question is whether the patients recognize the symptoms, whether AMS is available, whether the road network allows timely transport, whether the first hospital has CT imaging, and whether there is a system to transfer patients to a higher level of care when this is needed. So the stroke gap in rural areas is not just a treatment gap, but essentially a system gap in that sense. The same constraints they talked about for stroke also applied to TBI. Rural areas have a higher burden of road traffic accidents because the roads are not good. Many of these places may not have timely access to trauma centers, neurosurgeons, neuroimaging. The epilepsy section was important because it reminds us that disparities are not only about expensive technologies. In many of these rural areas, patients face stigma. There's an over-reliance on traditional healers, limited EEG neuroimaging access. Myasthenia gravis, they talked about prevalence may be higher because of exposures to pesticides. And even on top of that, advanced treatment modalities such as IVIG and plasmapheresis may be absent in rural hospitals. For TB meningitis, the authors discussed about delayed diagnosis and treatment and delay in treatment initiation, which can lead to much more complications and majorly neurologic complications. And then for tracheostomy, this may be controversial, but the authors highlight that in such resource-limited settings, early tracheostomy may sometimes be used as a practical way to reduce ICU stay to allow transfer to a lower level of care. But this should not become a substitute for providing appropriate monitoring and quality care, which sort of gives a balance of that. A major limitation of this is that it's a narrative review. Most data from specific LMICs may not be generalizable to others, like we've discussed. And the guidelines were based essentially on high-income country data, which may not be valid for LMICs. And there's limited cost effectiveness for LMICs. So in conclusion, urban-rural neurocritical care divide is deep and clinically relevant. Rural populations, especially those in LMICs, are disproportionately affected by delayed care and scarce specialist services. Improvement requires strengthening of the entire continuum of care, not just ICU bed expansion. Yeah, so Some of the implications is that there's a need for increased funding for rural health, expanding teleneurology services and other context-specific LMICs and rural disease guidelines may be helpful in the long term.
Thank you. No, thank you. And you had this graphic here. I don't know if you wanted to highlight anything here, Oliver.
Yeah, so this is just these graphics is just to highlight some of the unique challenges experienced by rural patients, not just in low, middle income countries, but even much more accentuated in these regions, including isolated geographic location, poor roads, and other infrastructural challenges that put patients in these areas at risk for poor outcome.
Fantastic. I just have one question. Oliver, to your mind, what's the single most important message for policymakers from this study?
Yeah, so the most important message is that the rural-urban divide in neurocritical care is not simply a problem of specialist availability. It is a reflection of the broader health system inequity. Rural patients face delays at every step of care, recognition of neurologic emergencies, emergency transport, access to CT imaging. For time-sensitive conditions such as stroke and TBI, these delays translate directly to poor outcome. So from a policy standpoint, the priority should be to strengthen the entire continuum of care rather than focusing on only advancing neurocritical care units. Many rural systems may first need reliable transport networks, may need a functional CT imaging, essential medications, trained frontline providers first, and basic ICU capacity before thinking about other aspects in the critical care pathway, I think.
That's great. That's great. Tommy, Aimee, any thoughts? Are you good?
So, Oliver, do you think that really kind of mastering the basics and really doing kind of basic neurocritical, not basic critical care rather than neurocritical care really outweighs the immediate need of neurocritical care, and that technology and neurocritical care partnerships via telenetworks or any of the kind of video networks would bridge that gap with technology, or what do you think is the binding theme?
Yeah, so for me, I think telemedicine and telestroke can be helpful, but only if the foundational infrastructure, such as electricity, internet, staffing, and receiving hospitals is there in the first place. So this review is essentially a call for a practical, tiered, locally adaptable investment in rural neurologic emergency care. If you have those basic infrastructure in place, then it's easy to build up on that and going forward is how I see it.
Yeah. Awesome. Well said. Well said. Aimee, are you good?
Yeah, just thinking about these patients or people trying to practice medicine without electricity, certainly have been in those situations, but not for long term. We really, you can't do any of these things without that.
Right. Yep. Totally. All right. The next paper was published in 2024 and is entitled Race, Ethnicity, Gender Disparities in the Management and Outcomes of Critically Ill Adults with Acute Stroke. Was led by Oliver, who's on the panel. And because of that, Aimee, Tommy, and I will be attacking this paper with vigor. So, Oliver, guide us through your paper.
Yeah, so our focus was on disparities by race, ethnicity, and sex. So what is already known is that Black individuals have a disproportionately higher incidence of stroke and stroke-related mortality compared with non-Hispanic white individuals in the United States. Certain groups of Hispanic of the Hispanic population may also have higher incidence of stroke, and women account for a disproportionately larger proportion of stroke deaths in the US compared to men. So one of the central questions we wanted to explore was whether differences in acute stroke systems, reperfusion therapy, ICU care, and post-stroke decision-making may contribute to some of these differences in outcome. This was, for the most part, a narrative review of the published literature. We summarized the existing evidence on disparities in acute ischemic stroke, intracerebral hemorrhage, and subarachnoid hemorrhage separately. In addition to reviewing all of these, reviewing prior literature, we also included a contemporary cross-sectional analysis of the national inpatient sample data from 2017 to 2020 that allowed us essentially to provide more updated information on disparities in intravenous thrombolysis usage, mechanical thrombectomy usage, mechanical ventilation, do not resuscitate others, in-hospital mortality and discharge outcomes in the United States. So in terms of our findings, one of the main points from the review is that disparities are present across almost the entire stroke pathway, is what I would say. For acute ischemic stroke, in terms of incidence, Black individuals in the United States have up to 2 times the incidence of stroke compared to white. So most of I would use men and women in place of females and males sometimes, just to be for appropriate, just to move the discussion forward. And most of my comparison is to white individuals, so I don't have to repeat myself all the time. So Black and Hispanic higher incidence, age and sex standardized incidence overall higher in males, but lifetime risk of stroke is higher in females because women tend to live younger than men. But actually, in patients less than 35 years of age, incidence of stroke is higher in women. Certain stroke types, such as cardioembolic strokes, more prevalent in women, more likely because they live older. Extracranial atherosclerotic disease may be more prevalent in men and in non-Hispanic whites. Strokes due to lacunar strokes more prevalent in Black individuals. Interestingly, even though lacunar strokes is more prevalent in Black individuals, strokes other than those due to extracranial atherosclerotic disease, cardioembolic strokes, at least based on more recent NOMAS data, may even be may have a higher incidence in Black individuals compared to non-Hispanic whites. So for pre-hospital stroke recognition, atypical stroke symptoms may be more common in women, so they tend to present more with headaches and non-specific symptoms and even when women present with more focal symptoms, recognition of symptoms by EMS may be less in women and less in Hispanic and Asian patients compared to white patients. And in the US, up to 60% of stroke patients present to the ED by EMS, but this percentage is considerably less in men and in almost minority patients. Men and women benefit equally from intravenous thrombolysis, but there's a race and sex disparity in IVT usage in the United States. All minority racial groups have lower rates of usage compared to non-Hispanic white individuals. And this data was consistent even in our 2017 to 2020 analysis. Some of these racial gaps in incidence has closed over time, but they're still present even up until now. Mechanical thrombectomy use, so for women, the IVT treatment gap has closed, but for racial groups, still remains. For mechanical thrombectomy use, interestingly, women have slightly greater odds of, with ischemic stroke, have slightly greater odds of having mechanical thrombectomy performed during stroke hospitalization. And this is not just in the US, it's also in studies from Germany and Spain as well. ICU admission, less odds of ICU admission in women, and this is from data from several trials. Older studies report higher rates in Blacks versus non-Hispanic whites, but these studies predated the widespread use of mechanical thrombectomy, so I don't think they count in quite it. Male sex and Asian race may be linked to a higher SICH risk, but non-symptomatic ICH-related bleeding may be more common in non-Hispanic Black patients. Dr. Viaglia and his group actually showed that 16% lower odds of use of decompressive hemiconectomy in women, higher odds of hemiconectomy in women compared to non-Hispanic whites. No difference between Blacks and non-Hispanic whites in that study. In our study, we showed that mechanical ventilation use was 30% lower in women with strokes. Even in the subset of patients with available NIHO scale, these odds persisted. And do not resuscitate status was also higher in women and lower in all minority racial groups. For ICH, Black patients were more likely to present with higher blood pressure, and data concerning surgical intervention in this group of patients was somewhat contradictory. But in general, most minority patients receive higher rates of life-sustaining procedures such as cranectomy, tracheostomy, or gastrostomy. In subarachnoid hemorrhage, there may be disparities in time to aneurysm treatment and modality of aneurysm securement, but these data are not as robust as they are for ischemic stroke. A major limitation is that this was a narrative review. Much of the evidence came from observational studies, registry data, or administrative databases, so we cannot firmly establish causation. Another important limitation is that many data sets do not capture all the clinical details needed to fully explain disparities. No detail in most of these data sets on stroke onset time, contraindications to thrombolysis, patient refusal, large vessel occlusion, treatment status. We also found disparities in intracerebral hemorrhage are much less well studied than disparities in ischemic stroke, and we think that's a major gap still in the literature. My main takeaway is that stroke disparities are not limited to one treatment decision. They are present across the entire stroke chain of survival, from symptom recognition, EMS use, hospital arrival, goals of care decision, and discharge disposition. But the clearest and most actionable inequity remains the lower use of reperfusion therapies in racial and ethnic minority patients with acute ischemic stroke. Yeah, so this figures is just to 2017 to 20 data, looking at thrombolysis usage in the United States. Blacks, this is Asian, Black, Hispanic, and white individuals. And as you would see in both men and women above 60, usage of thrombolysis is less than 10% in Blacks, and in most other racial groups in this period is well above 10%. Mechanical thrombectomy usage in primary ischemic stroke admissions over this time periods in Black individuals, at least in comparison to white individuals across the same period, was also lower. Sorry, I think I started slowly but I had to pick up the pace at the end.
No, we're good. First, I just want to congratulate you, Oliver. This is fantastic work, very comprehensive. There are a few studies that have looked across the board like this. So kudos to you for generating these insights that you did. In the interest of time, I don't have any questions, but I do want to call on other experts in case they have any comments or questions. Tommy and Aimee?
I have a
Aimee, go ahead. Yes, please.
Quick comment, I guess, more. I think about the trial or the study that was looking at neighborhoods for children, and also in my own clinical practice, we tend to see, there's days that I go into the ICU and I only have Black patients. I can look around and I have exclusively non-white patients. And I'll tell the team, we have to be perfect, because how are we going to overcome the barriers and the biases that they've seen until the point that they get to us? And it bears the question of if people are getting lower rates of thrombolytics and thrombectomy because they don't have access to it, or if it really is a bias once they are already within our our care. So it's just a comment and also a concern for sure.
Yeah, fantastic. No, thank you, Aimee, for that. I agree. I don't know, Oliver, do you have any response, or are you okay with that?
I think in the interest of time, I should we should continue.
We should continue. Okay, all right, all
Yeah,
right.
but I actually have a lot to say about that. Actually, the lower rates of thrombolysis in minority patients in general, I would think of is likely multifactorial. Firstly, delayed arrival to the hospital is the major reason why patients don't get thrombolysis, regardless of race. The most common reasons with acute ischemic stroke, patients, like I said, do not receive thrombolysis will be that they present late. EMS use and pre-hospital stroke recognition help patients get to the hospital earlier. Stroke awareness is also a factor. Like you said, health system trust, actually, what they've experienced in the past. And then in-hospital delays. In-hospital delays, like we also highlighted, it's more common in minority patients compared to Hispanic and to white patients. And not just to put all of those system issues aside, Black patients may be more likely to have higher blood pressure that need to be controlled higher. This also sort of not just puts the burden on the patient, but it also boils down to underlying structural problems that put them at that risk in the first place. So, and of course, there's also a small part that I think is related to treatment refusal and communication. So
No, I love that,
that's all I would
Oliver.
have to say.
I love that, Oliver. It's like, let's move on in the interest of time. No, this is too compelling to ignore. I love that. Girl, that's awesome. I love that. That was great. Thank you. I appreciate it.
Yeah.
All right. Our next paper is racial and ethnic differences in withdrawal of life-sustaining treatment and hospital referral in severe TBI, traumatic brain injury, was published in the Journal of Racial and Ethnic Health Disparities in 2025, led by Erin Hennessy. And we are going to be guided through this paper by Tommy. Tommy, please.
I'd like to say that everything up until this point has fed perfectly into the last three papers. This is all an analysis and highlight the fact that where you are geographically and who you are, your race, your ethnicity, your gender, all affect the care that you give, and that we need to really highlight that fact. So, talking about severe TBI, it's one of the worst surrogate decision-making context within medicine because there's a high mortality, there's hard prognostications, and the decisions are need to occur rapidly within hours to days on the clock. TBI at a glance, it really affects over 5 to 6 million people annually, globally. There's a 25 to 45% in-hospital mortality, and only 10 to 15% of those people have advanced directives. So prognostication is usually pretty difficult. The 2024 Neurocritical Care Society guidelines called outcome prediction extremely difficult, and the ACS recommends greater than 72 hours of aggressive care before transitioning to DNR or withdrawal of life-saving therapies. So to move on to methods, and if you could move to the next slide for me. So the the TQP is the largest U.S. trauma registry. It's got rigorous data abstraction, but limited participation centers. So the source of the cohort came from the TQP as well as the participant use files in 2022. Inclusion was by ICD-10 codes, as well as a GCS less than 8 at admission. And the outcomes were primary outcome of withdrawal of life-sustaining care with a secondary outcome of hospice referral. The analysis was by multivariable logistic regression. And so we had race and ethnicity collapsed into four groups for power. And so we see that our cohort ended up being 4,121 patients with an overall in-hospital mortality of 40.8%. 26% of those had withdrawal of life-sustaining therapies. 3.9% of those had hospital referrals. And so when you look at the adjusted odds ratios for withdrawal of life-sustaining therapies, non-Hispanic blacks had odds ratio of 0.49, Hispanics 0.59, others, which encompasses a group of that we'll talk about later, had 0.67, and non-Hispanic black had hospice referrals of odds ratio of 0.42. The median days before withdrawal of life-sustaining therapies was 2, well before the ACS 72-hour window, worth flagging regardless of race. And so to go back to the former slide, so there were several limitations to the study. The TQP gives a large N, but is a quality registry and does not have goals of care research tools. There's a pandemic era data which deserves flag. The ICU bed pressure also influenced the withdrawal of life-sustaining therapy timing, and the other bucket erases populations with different types of social determinants of health. The Alaskan Natives and American Indian populations, which have the highest TBI mortalities. So I'm going to go to the conclusions. So the disparities are real and statistically robust and are persistent. They're not really artifacts of small sample size. Hospice referral and trauma center is probably the most actionable gap, and there's well documented access disparities that exist across the nation. When we look at race and ethnicity, it remained in addition and independently associated with both withdrawal of life-sustaining therapy and hospice referral after adjustment. Non-Hispanic blacks had 58% lower adjusted odds of hospice referral. And so hospice utilization was very low in severe TBI overall. And the withdrawal window was very short. So the implications here, there are several drivers that warrant more mixed method studies. The whys don't really come up in this data set. Mixed method studies of why the withdrawal differs between race, whether it be cultural, religion, socioeconomic status, mistrust, communication. We need to capture surrogate identities, have more palliative care involvement. As far as practice, we really need to extend the window to 72 hours as the floor before withdrawal of life-sustaining therapies, and build hospice referral into severe TBI care pathways. This would also call, and we're going to talk a bit more about family meetings and engagement with families, just as we've talked about before, but standardizing family meetings where you get the same care, the same documentation for every patient. And from a systems approach, there really needs to be audits of withdrawal timing and hospital utilization quarterly that is stratified according to these different denominators.
No, thank you for that so much, Tommy. One question I have is, first, off the top, what is lost by collapsing the different groups together? Native Americans, Asian Americans, multiracial patients into a single other bucket.
Correct. So when you do that, you really don't get the most vulnerable patient signal. You do it in for power statistics, but you really need to look at those populations because they carry the highest TBI hospitalization and mortality rates nationally. So if you don't tease them out, then you really skip over that data group, which really doesn't highlight the problems that are occurring in those communities and doesn't offer solutions there.
Yeah, and it's a great point because, as you mentioned, many times it's done because of power. But this is where the point that you made about qualitative mixed methods work could come into play, where you could get samples and interview people and get a little bit more information, delve a little bit deeper, going beyond what power could not allow you to do. Let me just at this point ask if Oliver and Aimee have any questions or comments, please. No, doesn't look like it. Let me ask you another one, if I may, since I have your expertise at my beck and call today, Tommy. So if the median WST in this case occurred on hospital day 2, is the issue here primarily one of racial disparity, or is it more an issue of a broader trauma practice gap?
Well, I think you have to ask the question of whether there's really kind of a look at futility that occurs earlier in trauma. You see trauma patients come in and you get an idea of whether there's futility fairly early on, and so oftentimes that necessitates making a judgment call. Sometimes there was ICU bed pressure, particularly during the pandemic, but I think. I think if there's not ICU bed pressure, that shouldn't really move you in a way that really kind of limits resource utilization. I think there should be a uniform practice, and then you should kind of decide whether that practice is suboptimal because I think TBI prognostication is so poor, and it's uncertain, and especially in the early days.
It's great. All right. Nicely done. We'll now move to our 8th article, published in Neurocritical Care in 2024, led by Paula McGee. And this looks at the issue of culturally centered palliative care, examining a framework for equitable neurocritical care. Tommy, the floor is yours.
Awesome. So, health inequity for racial, ethnic, minoritized groups is a really kind of a public health emergency. It's not a marginal issue. The Black-white mortality gap is widening. It's the 15 for the 15 most common neurological diseases, it's widened significantly since from 2011 to 2019, and we're not closing it. Stroke and TBI disparities are documented, and we talk about how 80 to 90% of our outcomes are driven by social determinants of health. You are 3 times as less likely when you're Black to have your preferences honored within the hospital, and so. We know that racial is a social construct, not a biological one, and so we really need to come up with a framework for addressing these issues. If you can move to the next slide. So, as far as the methods, so this is a narrative review. It's not a primary research study, and it synthesizes U.S. focused literature on stroke and TBI, palliative and end of life disparities. It builds on center to advance palliative care and improve palliative care in the ICU recommendation. And it proposes a 4-pillar anti-racist framework mapped to palliative care tenets. There's no empirical validation against equity outcomes yet. And so the again, the most powerful data point that we had was that Black patients' preferences for life-extending care was honored 3 times less often than whites. But there's a bit of a paradox because clinicians are more likely to recommend withdrawal of life-sustaining therapy to minoritized patients in family conferences, and those families often decline. And so these 4 pillars map directly to palliative care tenets. We want to affirm narratives, which is acknowledge, as Aimee said, acknowledge the ills of the past, acknowledge our racism's impact, actively listen to the patients, ask open-ended questions, and then we want to lead with empathy and dignity. How we talk to them, greeting with surnames, eye contact, open body language. Um, Next, we really want to honor what their values. We want to engage the families early, align plans with the patient's values rather than our own. And even when there's a conflict, we want to supersede their values over those of our own. And lastly, we want to practice a cultural humility, acknowledging our own biases and our own ignorances, and self-reflect on what we know and what we don't know, and recognize how preferences probably have been shaped by things that we don't even know are at play. And the 4 tenets of palliative care that these align with are reducing pain and symptoms, align treatment with values, alleviate emotional distress, and provide end-of-life care. If you can go back to the former side. So there are a few limitations. This is a roadmap, not a tested intervention. It's obviously a heavy lift on individual clinicians without parallel structural changes that produce thoughtful clinicians inside of this inequitable system. And so future work really needs to measure, do these behaviors actually change documented disparities? Um, in conclusion, it can be said, and this is a quote from the article, that practicing medicine without an appreciation for and an active attempt to dismantle the systems that lead to disparate health outcomes can no longer be considered providing quality care. And so we really have to look at ourselves as equity being our job. It is our bedside job, and it's not someone else's job. And communication is our key clinical competency within this area. It's not a soft skill.
Outstanding. Outstanding. Thank you for that, Tommy. So my first question is there evidence that individual clinician behavior change moves population level disparities, or do we need a structural level intervention?
I think we need both. The evidence behind individual change is very thin, not a lot, but there is some that show that it improves patient experience, but it's not yet demonstrated to close mortality gaps or care utilization gaps. And so I think we really need structural drivers, social determinants of health, insurance, geographical stroke centers, to really push larger variances. The framework that we have here is probably not sufficient, and we really need structural change, which often is slow.
Oh, agree. Now, this question has to be asked, especially during times like this. The framework uses anti-racist language with abandon. How should we navigate that with audiences who find that framing polarizing, especially now? And is the framework defensible without the label? And Tommy, lead the discussion, but I'd love to hear from Aimee and Oliver if they have any comments about this.
Well, I think you can obviously do the framework without the label. You can obviously move forward, but without the label, you really skip over what the initial problem was, and you really don't lend credence to the antitrust, the worries of the patient population that you're often treating. You lose that diagnostic step of admission of the ills of the past and our own inherent biases.
Aimee, Oliver, any thoughts?
Yeah, I agree that you certainly have to individually acknowledge trust of the system, on a daily basis with individual patients. I think when you talk about anti-racism language in this current political climate, we cannot, we will not be perfect. We cannot be. I mean, we have legislation that says our executive orders that say we can't use certain words, which means that we are diluting the language in effect. However, the work must continue, and if the work goes underground for a bit, or if the work becomes coded, that is better than not doing it at all. So I think it's a balance between doing the work in an individual level without having it shut down in totality.
And
Well said.
to Amy's point, I mean, often the statement of anti-racism can seem performative. And so rather than be performative, do the work, get the work done, without the necessity of a title, but know what it is that you're doing and know what it is that you're teaching and continue to propagate the message forward.
Amen to that. Amen to that. Oliver, anything for you on this one?
No,
Okay.
this was good.
Thank you. Thank you. All right. Our last article published in Seminars in Perinatology, led by Gabriel Fernando Verian, addresses remote neonatal neurocritical care from the bedside to the cloud. Tommy, take us home.
And so this last article is really brings things together. It really is the most forward-looking of the articles, but it touches on a lot of the points about technology, infrastructure, equity, rather than simply bedside disparities. It was a Brazilian-led group that brought the lower middle income perspective that U.S. papers kind of miss sometimes, and the disparities are really global. The This all really matters because neonatal neurocritical care is often concentrated in tertiary care centers, and most NICUs lack specialty access. The disparities are global. So, again, the pandemic caused telehealth to really blossom, and publications about telehealth grew twofold, and so we really need to kind of look at this because only 29% of providers really have formal training, and we need to try to bridge that gap. So if you'll go to the next slide. So this was a narrative review, and it was heterogeneous evidence quality across multiple cited programs. The narrative review structure really looked at reviews of telemedicine plus digital health applied to neonatal neurocritical care, and it synthesizes case examples from published programs. It provides a nine domain comparative framework, traditional versus traditional versus remote neonatal neurocritical care. And so from the results, we see that it's really remote neurological exams matched in-person exams in 92% of the abnormal case. 54% of consults were able to be managed locally with a savings of about $900,000 in transport savings. There's an 85-day reduction in time to first therapy, a 97% access early intervention, and 872 neonates were monitored across 32 hospitals. The the There were again multiple domains. We see telerounding and consult, video EEG interpretation, multimodal monitoring, neuroimaging review, the teleneuro exam, the teletherapy follow-up, teleeducation and mentorship. There's talk of AI twins in the future, which is you're basically going to build an AI copy of the patient to have predictive analytics, but that is definitely not prime time yet. But there is a caveat to all of this. Neonatal neurocritical care can widen inequity if it's deployed only where infrastructure already exists. And we've previously spoken to this problem several times before. The lack of infrastructure and the definition of low middle income countries can span a wide swath from lack of electricity to simple lack of access, lack of transportation. And so there's a potential that this can widen the gap as much as it can treat it. If you'll go back to the former slide. So again, infrastructure, because connectivity is key. If we don't have equipment or we lack connectivity, then obviously we're not going to be able to use this as a tool. There's a possible lack of interoperability because EHRs and devices don't really speak to each other very well. There's training variability. There's also privacy issues because patient data, consent is floating through the ether and can easily be picked up and used for malicious intent. And we all know about the concerns that we all have about AI because right now there's limited transparency and there's limited real accountability on what happens on the other side. And so these things can potentially widen an equity gap and cause further problems. So the technology can work. It can redistribute capacity, but it won't create it. And I feel like though the article talks about feasibility, it's not really talking about at scale equity. This is a demonstration of feasibility as this being a possible tool that helps, but it is appropriate. The article is appropriately cautious, I think, about that. And so the implications of this can be broad, but we also need to remember that AI and these tools are human design. And so we can build in inequity if we aren't careful. And so we have to be careful to build equity into the design, the training, the governance, the infrastructure. And we really need partnerships locally, as we spoke of before, to assess the needs of those that we're trying to serve. And this should be an iterative process of the telehealth programs really being evaluated for outcomes and equity of access in an iterative fashion.
Well, that's great, and it's wonderful to have this futuristic article as the last article, and in many ways it embeds many of the themes that we had identified before this. I have one question. What are the medical legal implications when a remote consultant disagrees with a bedside clinician's judgment, and how is that being handled?
So the short answer is we don't know. This has not been proven out over a long period, but what we do know is that the court often follows the bedside clinician's record and what they have done. But the courts have really been inconsistent about remote subspecialties care. They can call it a curbside, but the local physician generally remains the final authority on what's happening. And so that can often create a tension. So the malpractice coverage really varies. So there's not really knowledge of what will happen kind of in a medical legal standpoint to be determined.
Aimee, Olive, any thoughts, questions?
No, I think this is a great way to end today's discussion. Thank you.
Absolutely. Oliver, you look good. Okay, great. Well, I want to first of all say a big thank you. Big thank you to Dr. Aysenne, Dr. Otite, Dr. Thomas for giving us the time and the effort to better understand these very important articles and issues. I really learned quite a lot, and I hope our audience does as well. I will get on my soapbox, if I may, and just say that I would love to see in the future more of these studies done in a systematic way. One theme that I noticed was everything was narrative, which is great, but it would be lovely to have a little bit more rigor applied to this. And I know it's easy for me to say, but I would love to see more of that. And of course, we anticipate having future neurocritical care episodes of Disparities Dialogue, and we hope our experts will be willing to come back and help guide us through those papers. But I think it was a wonderful session. And again, a big thank you to all three of them. I also want to take the opportunity to remind you that Disparities Dialogue is part of SEQUINS, the Society for Equity Neuroscience. We have several channels in which we do activities within SEQUINS. We have our annual meeting, which is next week. It's a hybrid conference in Charleston, South Carolina. So feel free to come in person or join us virtually. We have our scientific journal called Equity Neuroscience. We've been publishing quite a bit, so please feel free to submit your papers to us, or feel free to even review for us. We have our audio podcast called No Brain Behind. It's fortunately well subscribed, and so please feel free to tune in. And then finally, we do have experts from time to time speak to us about the state of their science, and so please also tune in for that. But again, a big thank you to our experts. Next month, we are going to be focusing on headache disorders, so please return for that particular discussion. Thank you all so very much.